Hi, everybody. Hopefully, you watched the first lecture of the Intro to Long-Term Care. And I apologize, there was a technical difficulty, but I wanted to make sure I got the video up for you. So the video was taped from last year, but all the material is still relevant. And so hopefully you did watch that. And if you haven't, please shut this video off and watch the first one first. Couple announcements that I want to talk about is this week is, as I said in the email, these are taped lectures. I did post the discussion questions and the ability to upload that assignment there. We will next week also have a taped lecture with discussion questions that'll be due. And then on the week of Tuesday, October 17th, we'll be doing a live GoToMeeting chat session, which will occur between 6 and 9 of our normal time. So please make sure you block that out. And we'll actually be doing a nursing home case and doing a lecture in the process. So hopefully in the original lecture that you watched, I went into detail talking about the importance of the medication regimen review and also the history of where we are as consulting pharmacy. As I said in the prior lecture, long-term care and from a pharmacy aspect composes of the importance of the distributive side, because most of these nursing homes don't have pharmacies there on site, so they're relying on partnering with a pharmacy. Most long-term care pharmacies are closed-door pharmacies, and they do get advantages with contract pricing. They are also specializing in special type of packaging to be delivered to the pharmacy. The other most important component is the clinical component, and this has been in existence since 1965. If you followed my history lecture I had with the prior video, is that it's been a work in progress. And unfortunately, what's happened over all these years is it does help try to catch up to what's going on clinically in practice in pharmacy, but a lot of times too, it's just kind of rehashing the same laws that have been passed and just trying to enforce them better. But both are essential for providing high quality for patient care. And then the other most important thing is even if you're the consultant, you'll go back and forth in helping with the dispensing and distribution and making sure that occurs. I did also talk about in the last slide that the most important part that we need to look at, and this could be applicable to any practice setting, but especially in long-term care, is what is total drug cost. It's not just the product itself, but how well it's being utilized, how well it's being dosed, because we're dealing with a higher risk population that is more susceptible to adverse drug events and possible therapeutic failures. As I said in the last lecture, I went over the history of consulting pharmacy, and one of the things that I emphasized in this lecture is that when we're talking about traditional skilled nursing facilities, which this is what we're going to be talking about over the next couple weeks, the last lecture I do have near the end of the semester is I do talk about some of the regs in assisted living. But here in the state of Pennsylvania, as in all states, the Department of Health and Human Services of the state helps work and establish the regulations in conjunction with CMS. And CMS helps determine what are those requirements. And so in order for a facility to be able to bill Medicare and Medicaid, which is the majority of the business, that they must follow these rules. And to get certified annually, there has to be a survey that occurs. In 2006, we saw one of the biggest overhauls from the pharmacy service standpoint, and we saw a change in the different F tags. And this is what I've been lecturing over the last several years, and we're going to highlight these. This week we talked about medication regimen review. What we're going to talk about next week is unnecessary drugs, and also another important aspect is the appropriate controlling label and storage of medications. But there has been a change over the last year here of the requirements for homes that want to participate in Medicare and Medicaid. And really, this is an overview of requirements that really haven't had a significant change since 1991. So we're not just talking about pharmacy services, but this is still one of the biggest changes of this is really holding nursing homes accountable to a lot of the laws that already are on the books and falling into that same line that has occurred with the Affordable Care Act, that we're looking more at a value-based type of payment delivery service. The theme of this long-term care overhaul rule that is going to be implemented in multiple phases is that nursing homes are more person-centered care. Although quality has been emphasized over the years, it's being emphasized even more. That the facility assessment and competency-based approach may affect the way facilities are reimbursed in the future. Making sure this is aligns with other health and human service priorities, and making sure that they're up to date in modernization. This overhaul of the rules helps reorganize, update, and stay consistent, and it is going to be implemented in multiple phases. The first phase, which occurred last November, is taking existing requirements that are relatively straightforward and making some minor changes of how those are going to be enforced in the survey process. Phase 2 is going to need more time in educating surveyors of how to make sure those foundations are occurring. And phase 3 is going to obviously have more trainers to be able to make sure this is implemented. So this is a 3-year process that is going to occur. During this process, multiple areas of the regs are being addressed. And if you see here in phase 1, pharmacy services are being addressed, but won't be fully implemented until phases 2 and 3. Other phases that are being looked at is such as things as quality assurance, improvement, behavioral health, infection control. And so the timeline of these, as I said before, started last November, going to have a second phase this November, and it's kind of restructuring what the requirements for nursing homes to participate, following the laws, and making surveyors are enforcing those laws. Phase 2 of long-term care regulations, which is going to begin this fall, is making sure that nursing homes are focusing on comprehensive patient-centered care planning. Pharmacy services are really enforcing the unnecessary use of psychotropic medications and numerous other areas there. I showed you just prior to that that pharmacy has numerous F tags. One thing that did occur was restructuring those, and so the pharmacy service regs, which are very similar to what they have been, are going to be aligned under FTAG 483.45. So all those FTAGs I showed you, 424, 425, 329, are all going to fall under one chapter area called pharmacy services. So what is required under pharmacy services? That it's going to pretty much retain existing requirements, but just modify it to a little extent. That the nursing homes are required for more reporting requirements, more up-to-date policy and procedures. And so what I went through that first lecture, what you learned about medication regimen review, is pretty much what's going to still stay in place, just going to be enforced a little bit differently. So one of the things that's important that occurs at the nursing homes, and I can tell you that this actually was occurring before this law changes, at least in the nursing homes that I worked with, is that we've always had a policy and procedure of what's required for a drug regimen review. There's been some change of definitions of what is a psychotropic drug and changes of definitions of what actually is a medication irregularity and how pharmacy will address this. And then the other thing that's important that CMS wants to make sure that all staff members, including physicians, prescribing practitioners, are aware of the importance of the monthly drug regimen reviews done by a pharmacist and how they must act upon those. So one of the things that should be occurring this past year in phase 1 is nursing homes should have been auditing, making sure drug regimen reviews were being done appropriately. Another thing we're going to talk about this later on in lectures is pharmacy is heavily involved in evaluating nurses and evaluating medication error rates and coming up with resolutions of helping to either prevent or to improve risks for medication errors. And all of this should be incorporated. All nursing homes have a quality assurance committee. Pharmacy usually sits on this quality assurance committee, And all this requires is that pharmacy in this process is going to be worked on that year. So a couple things that have been necessary that have kind of already existed but just being reinforced is that a review must include the review of a resident's medical chart. And this distinguishes from just the MAR. One of the things that occurred in 2006 that was kind of lifted was it said that consultants could do some of the reviewing remotely, not necessarily be at the home, but that was more emphasized that it should be done if you have access to electronic health records. But this is reinforcing that the pharmacy should be having access to the medical chart and making those evaluations, whether it's paper charts or electronic health records. The other thing, too, is what requires a drug regimen review. Obviously, I don't think it's going to change, but every resident should be reviewed every month. But they're really going to, the surveyors are going to look at is that when a resident is new and has not previously been in the center, what was the timeliness of a review? When a prior resident returns from the hospital or other centers, what was the timely review? One of the things that I would do when I would go to a nursing home, I would stop at the director of nursing office, ask them if there's any issues of any particular residents they want me to look at. And all the time I would get a copy of the admissions report since I last was there. And those admission reports would list any new residents or any returning residents from the hospital. And I would immediately look at those residents to see if there's any significant issues that I need to address that could have occurred during the transition of care. The other thing is monthly when a resident is taking psychotropic drugs, antibiotics, or any identified drugs that need to be monitored, that there is a reporting of what does occur. And pharmacy has been doing this for years, being the psychotropic police. It's just that these new regs are helping enforce that that's occurring even more likely so. The definition of irregularity in the CMS regs has really been there, and anybody who's had any good clinical pharmacy training was aware of what was an unnecessary drug is what we teach in pharmacy school every day. That if a drug has an excessive dose, if there's duplicate therapy, that it's being used longer than it should be. For example, PPI, it's not being monitored appropriately, such as if I'm on warfarin, I'm not getting an INR. There's no actual true indication for it, or there's presence of possible adverse consequences that either we need to reduce the dose or stop the drug. Those are all significant practices we do every day when we identify drug-related problems. And so those don't differ. It's just the laws are trying to reinforce that surveyors who are evaluating, who may not necessarily be pharmacists, that this is occurring. The other thing that's being required, which I would do all the time when I did my reviews, is I would provide a written report. And this written report would always go to the director of nursing. But now this is making sure this is also going to the medical director of the nursing home. And always if there's an irregularity, it's always been implied that the pharmacist should be providing that note to the physician and stating who the patient is, what was the relative drug that there's an issue, and identifying the irregularity, and hopefully also giving the outline plan of what you'd like that physician to do. Once again, that had been being done. The only thing is that there's going to probably be more enforcement that if a physician does see the note, that they're documenting that they saw it, and if there's no action taken, they need to document the rationale of that medical record. And that was kind of implied in the updated regs in 2006. And this new update is just kind of really more enforcing that this is occurring. And so nursing homes should be working with their quality assurance committees in that at their meetings, there should be reports reviewing what drug regimen reviews were done, how many irregularities were reported for the month, how were the physicians acted upon them. If there's psychotropics or other drugs that need gradual dose reductions, those reports should be reviewed at the quality assessment, and also med-air reports. But I can share with you too that, when I was doing nursing home consulting, a lot of my quality assurance committees, this is something that I was already implementing. And so this is just, once again, this updated regs is kind of enforcing that. And we'll talk about reporting in the coming weeks. The definition of a psychotropic drug has always been implied that it might be an antipsychotic, antidepressant, anti-anxiety, or hypnotic, but basically the definition broadens it that any drug that affects brain activities associated with mental processes and behavior. So that could include things such as anti-epileptics or any type of drugs that could cross the blood-brain barrier. What you're going to see in phase 2 being implemented this coming fall is that patients do not receive psychotropic drugs pursuant to a PRN order unless the diagnosis supports a condition in the medical record. There's a lot of evidence that PRN orders are not really effective. In fact, PRN orders, all they do is occasionally sedate and may put people at more risk. And the other thing is, if there is a PRN order for a psychotropic, they should be limited under the length of the order to 14 days unless the physician documents in the medical record the rationale for continuation. The only problem you got to be careful with this as a consultant, that if it's a drug that you can have abrupt withdrawal, such as a benzodiazepine, that depending upon the dose, if 14 days occurs, there should be some type of tapering plan. So the survey process, which we will talk about the survey process in coming weeks, is it looks at things such as the quality indicators of what might indicate whether or not there's poor care occurring at the nursing home. And we'll talk about this actually in 2 weeks when we do our live chat of how pharmacy can be affected and emphasize and improve quality indicators. It will evaluate the regulatory changes and whether or not the nursing home is enforcing them, such as the physician reviewing the notes and making sure that data is being tested. Some other things that in the medication regimen review is the drug regimen of each resident still should be reviewed at least once a month. The pharmacist should still be reporting to these, and these reports have to be acted upon. A couple of things that, comparing the current to new rule is that the monthly review is done. The reports of the irregularities, like I said, but the new requires the monthly review of each resident's drug regimen by the licensed pharmacist. Also includes, that it is part of the medical record, where in the past sometimes the pharmacy regimen reviews might be separated from the actual chart. The new rule also requires reporting irregularities not just to the director of nursing, but to the medical director. And this actually had been occurring, in my opinion, but making sure those notes are getting to the attending physician. The new requirement that a physician document and review the pharmacy report, and if there is an action taken, that order should be implemented. If there is no action taken, they need to document why. And there should be a policy and procedures to make sure, quality assurance-wise, that this is being enforced. The other thing too, that actually, just to share with you, when these new regs were being looked at and adopted, as I said, it accepts comment to require pharmacists to review the medical records monthly. I'm not aware of where this rule was that it was only every 6 months. It has always been implied that it should have been reviewed monthly, but that might have been occurring. There was a suggestion that maybe these reports be shared with residents' representatives, such as caregivers, healthcare powers of attorney, family members. That actually has been declined and is not required. It also affirms that the rule that the medical director be informed of those irregularity reports. And the medical director, if they get that report, they need to make sure that their fellow physicians, prescribers, such as nurse practitioners, are enforcing. One of the things that had been proposed, that you do see this in some states, is that some states require the consultant pharmacy to be independently contracted and be separate from the dispensing pharmacy. Example of a state that does that is New Jersey. There was a suggestion that this should happen at the national level. However, some of the bigger long-term care chains vehemently opposed this, and it actually got shut down. So as of right now, there is sometimes can be a conflict of interest where the consulting pharmacist is employed by the dispensing pharmacy. As I said before, the director of nursing and the attending physician are not required to agree with what you write. However, they need to act upon it. And that's why that's so important, because if they act upon it and they provide the rationale, then it'll show why this was either done or not done. Couple things too, just to highlight for what you saw in the prior lecture. I just want to reiterate that a medication regimen review is no different, in my opinion, outside of you may not be directly interviewing the residents at sometimes just because they can't be interviewed, is that you're doing a good comprehensive review of the medications. You're using that review to prevent, identify, and resolve any medication-related problems, identify any med errors, and collaborate with other healthcare professionals to resolve those problems. A medication-related problem is everything you've learned about drug-related problems. It could be a medication without an adequate indication. It could be a medication that doesn't have good evidence to be used in that patient or that patient population, such as geriatrics. That the appropriate medication, maybe they're on a blood pressure medication, but they're not reaching treatment goal. The timing, the technique, the administration, those need to be appropriate. So if somebody's on a drug that's very stimulating and they're being given at bedtime, and that's requiring them then to be on a hypnotic, we need to make a recommendation of switching that to morning dose. Use of medications in excessive dose, such as evaluating whether or not they are renally cleared, and they may need to be renally dose adjusted. They may be weight-based. They may need to be adjusted based on that. And always we're trying to help prevent adverse consequences. Another key thing that it's our responsibility to make sure that drugs that need to be appropriately monitored for labs to prevent ADRs or to evaluate efficacy, that those are being done. Another thing that has to be done is pharmacists need to do med passes to evaluate the risk of med errors in the home, and obviously checking for drug disease and drug-drug interactions. As I said before, we'll go through the process here in the coming weeks of how does a pharmacist evaluate the risk for med errors, but this also has to be done and needs to be reported on a monthly fashion to the quality assessment team. So that was a brief update of how the regs have changed. As I said before, you should have watched the initial lecture. Please review the discussion, look at the discussion questions. I do ask you to submit those. I did provide some additional readings to help supplement what we've talked about here. And I also did post a nursing home case. And that nursing home case, I would like you to just start to begin to review. And next week, I will kind of go over the nursing home case, because what we're going to do for the following week of October 17th is you're going to start identifying possible irregularities that you see with that patient. Okay, thank you very much. And please send me an email if you have any questions of this lecture or any problems reviewing it. Take care.